So welcome to diagnostic workup of patients with uncontrolled severe nasal polyps, proposed pathway to determine candidacy for biologic therapy presented by the Global Educational Group in collaboration with the Asthma and Allergy Foundation of America, broadcast on immunologylive.com and resinsightslive.com. My name is Eugenio De Corso, physician in the unit of otorhinolaryngology at Agostino Gemelli University Hospital Foundation. I'd now like to introduce my co-presenter, is Dr. Marco Caminati, physician in the Asthma Center and Allergy Unit of the Department of Medicine, University of Verona and Verona University Hospital. Thank you, Marco, for joining me today. And let's get started. Here our disclosure. And let's go to learning objective of today. We aim to identify patient factors to predict relapse risk and determine candidacy for biologics. We want to discuss emerging models for interdisciplinary collaboration in the care of people with nasal polyps. And I'm very excited to share today this talk with Marco, so please stay tuned until the end. In each section, we will discuss our collaborative approach to managing patients with uncontrolled severe nasal polyps, including diagnostic workup, treatment, and follow-up. And I hope you can learn how we use our experience as an ENT and allergologist to find the best treatment option for each patient. And let's start now analyzing the burden of chronic rhinosinusitis with nasal polyps, and in particular, the standard of care in the past. And over the years, we treated this pathology with a stepwise approach, starting with topical treatments, including intranasal corticosteroids and nasal irrigation, stepping up to systemic medical treatment if needed, and especially with short course of systemic corticosteroids, and finally to surgery if we didn't reach an adequate and a satisfying control of symptoms. But unfortunately, in the past, this approach led in severe cases to a vicious cycle of treatment and to a chaotic journey for the patient. And now we realize that we have to do our best to avoid the delays in diagnosis, followed by years of inadequate control in these patients, because in that case, we can observe persistence of anosmia, facial pain, headaches, anxiety and depression, high levels of fatigue, and poor quality of life. And everyone knows the risk associated with systemic steroids treatment, and in particular to the short-term ones, such as hyperglycemia, hypertension, mood disturbances, nausea, and sleep disturbances. But we are even more worried about long-term consequences of the use of systemic corticosteroids, and in particular, anxiety and eye problems such as cataracts and glaucoma and depression, and the increased infection risk, the risk of osteoporosis and of the skin problem, and also the risk of the weight gain. But now everything is changed, because nowadays we know that type 2 inflammation is associated with more severe disease in that patient, and particular in the patient with loss of smell. And we know that the type 2 inflammatory endotype are high prevalent in our country and especially in Western countries. And in that patient, we can use biologics that target underlying inflammation, inhibiting mediators of the type 2 inflammatory cascade. And here we want to remind you that basing on the EPOS recommendations, biologics are advised after an adequate medical treatment or surgery. So if the patient doesn't have an adequate disease control after an adequate medical therapy and surgery, additional therapy is advised, and especially biologics. And who are the right candidate for biologics? So basing on the new classification of the EPOS 2020 guideline, we nowadays know that the right candidate are patients with primary chronic rhinosinusitis, with a bilateral diffuse disease, with an endotype type 2, and with a clinical pictures of severe uncontrolled chronic rhinosinusitis with nasal polyps.
So thank you, Eugenio. So you clearly mentioned that relapse is part of the disease history for those patients. Is there any determinant or biomarker able to predict an higher risk for disease relapse in patients suffering from nasal polyps?
Oh, thank you, Marco, because this is a crucial point. I published in the past a paper on predictors of nasal polyps recurrence after endoscopic sinus surgery. But nowadays, I prefer to speak about predictors of poor outcome. And they are very important to be identified before endoscopic sinus surgery. And they include clinical factors such as asthma and aspirin intolerance, and the presence of Staphylococcus aureus superantigen, eosinophilic infiltration, biofilms, and neutrophilic infiltrate. And also, it's very important to consider that negative predictors of good outcome are lack of adherence to intranasal corticosteroids or inadequate surgery. And we also tried to quantify that risk, the relative risk, and we observed that the worst predictors were aspirin intolerance, nasal eosinophilia, and mixed patterns of inflammation, eosinophilia, and neutrophilia together.
Right, very interesting. So you mainly focused on biomarkers. Is there any clinical feature predicting an higher risk of relapse, including symptom scores or olfactory dysfunction tool?
Oh, you're right, Marco, because also the symptoms scores preoperatively are very important, and especially if we evaluate the impact on quality of life by SNOT-22. So the literature data are clear, and the SNOT-22 scores are a good predictor of outcome after surgery. And as a separate consideration should be made for olfaction, because it's very difficult to predict the recovery of sense of smell after surgery. But one predictor is the fact that the patients can recover a good sense of smell before of surgery with oral corticosteroids. But even that, we cannot predict for how long after surgery the patient can retain a good sense of smell. So it's very difficult to predict recovery of a good sense of smell after surgery. And finally, obviously, primary surgery has better outcomes compared to revision surgery. But if we face with failure after surgery, what we should do? We suggest to analyze reasons of failure. So we suggest to repeat an additional workup, trying to define the treatable traits, and also repeat endotyping and phenotyping again, reconsider the possibility of a secondary chronic rhinosinusitis, and also to repeat the screen for comorbidities. And also it's very important to analyze previous treatments and in particular timing and number of previous surgery. We have to check if the previous surgery was adequate and complete, and also if the medical treatment, the previous medical treatment was adequate. It's finally important to check for adherence to post-operative medical treatment. And after we re-evaluated all the possible causes of failure, it's very important to analyze factors that may help us towards the choice of surgery or biologics, because there are factors that may orient towards surgery, such as a good long-term symptom control after first surgery, or poor symptom control with previous biologic treatment, or even refusal of long-term, long-life treatment by the patient. And also, revision surgery may be required to correct some wrong consequences of previous surgery. But there are also factors that may orienting toward biologics, such as early recurrence of symptoms after last surgery, significantly olfactory dysfunction, also multiple endoscopic sinus surgery without reaching an adequate control, or a previous complication of endoscopic sinus surgery, and finally, contraindications to general anesthesia. And now the talk is over you, Marco, to speak about the models of multidisciplinary care for people with chronic rhinosinusitis with nasal polyps.
Thank you, Eugenio. Thank you very much. Well, you have quite clearly depicted the complexity of that condition, but let's analyze some further reasons why the multidisciplinary care approach is needed and recommended. If we have a look to the common and less common type 2 conditions, including asthma, asthma with aspirin intolerance, allergic bronchopulmonary aspergillosis, EGPA, or hypereosinophilic syndromes, well, the involvement of upper airways is quite frequent. It is characterized by a very recurrent manifestation in patients suffering from those conditions. It represents probably the most bothersome clinical manifestation and the reason why the patients go and visit the doctor. And following that kind of epidemiological data, we recently focused on the need for a step-by-step approach for those patients involving more than one specialist. So in this algorithm, we included allergists, of course, pulmonologists, ENT specialist, pediatrician for the transitional care setting, and to some extent a dermatologist. Why? Because we need to be a task force in order to correctly identify the diagnosis of our patients, which is not only the involvement of upper airways, but also the potential coexisting type 2 or non-type 2 comorbidities along the respiratory tree, but also besides the respiratory tract. We also need a multi-dimensional evaluation in order to identify the best treatment for our patients and to scheduling a proper follow-up over time in order to evaluate the opportunity for a better tailoring of our initial therapeutic approach. In particular, we have to ask ourselves if the patient is a good candidate for a biologic treatment at the time we are evaluating him or her, and how to select the right treatment among the options we have in our hands today. So regarding the first question, well, the currently published international guidelines do support us in correctly positioning the biologic treatment, but there are some controversial points in relation to the best eligible patient or the right time to initiate a biologic treatment, especially in relationship to surgical options and prolonged medical treatment. So when we have to define the best candidate for the new treatments, we have to combine somehow, on one hand, what we know about the mechanism of action of the biologic treatment, of the targeted therapy we are thinking about, including its efficacy on potentially relevant comorbidities our patient is suffering from besides nasal polyps. And on the other hand, we have to have a look to the evidence from the literature related to the efficacy and safety profile of our treatment options before defining that it is the best option for our patient. The international guideline here, we have a combined overview of euphoria and EPOS, suggests some criteria and related cutoff points in order to define the patients best responding to biologic treatment. So by evaluating total IgE or blood eosinophils, we have the chance to define a type 2 inflammation. By investigating the number of OCS trial during the year, we have the chance to evaluate like the severity grade of our disease, as well as its impact on quality of life of our patients through the SNOT-22 score. We have the opportunity to investigate the smell impairment, as well as the coexistent severe or not severe bronchial asthma, which is probably the most frequent condition coexisting with nasal polyps. And besides that, we have some other tools in order to identify a type 2 underlying inflammation or to define the severity of nasal polyps, including some radiological and endoscopic scores. Or we have some further tools to define, to investigate also the olfaction impairment, including the sniffing sticks or the APSID methodology. But anyway, what is crystal clear is that a multidisciplinary evaluation is always required, even in the light of what we have seen before in relation to the upper airways involvement or of more systemic diseases usually characterized by high eosinophils in the blood, but also in the light of the potential trajectory of our patients suffering from nasal polyps and severe asthma, who might develop over time an GPA or a more systemic disease. We have the chance to live a very privileged era now, because we have very targeted, high efficacy, effective drugs, biologic drugs. And if we have a look to the currently labeled biologic treatments for nasal polyps, it is quite clear that their indications also cover some potential coexisting type 2 condition. So it means that we have truly the opportunity to tailor the identification of the best biologic drug according to the clinical and pathobiological profile of our patients. Looking at the mechanism of action of the currently labeled biologic therapy for CRS with nasal polyps, well, we have some options directly targeting eosinophils. It is the case of mepolizumab targeting IL-5, which is the most relevant cytokine for the survival and production of eosinophils, and benralizumab, which targets the IL-5 receptors, involving also NK cells. But also dupilumab, targeting IL-4 and 13 receptors, has the chance to interact with the most important drivers of type 2 inflammation, as well as omalizumab, which specifically binds total IgEs. So once that we have selected or identified the best treatment option for our patient, we need to follow up him or her over time, and we need to regularly assess the treatment response to biologic and how we have to assess that kind of clinical response. So we have some nasal-related outcomes, so directly in relation with the main reason why we prescribe the biologic treatment, and we can evaluate, or we should evaluate, nasal obstruction, smell impairment, rhinorrhea. But if our patient is suffering from other disease coexisting with nasal polyps, well, we have to assess the impact of the biologic treatment even on those coexisting conditions. Maybe asthma control, maybe the GPA or hypereosinophilic syndrome, under the light of a potential evolution of the nasal condition towards more systemic disease. And of course, we have to assess the safety profile of biologic treatment. So, Eugenio, what about the implementation in clinical practice of that multidisciplinary approach, which is absolutely needed for the standard of care of those patients?
Well, thank you, Marco, for your overview and a nice talk. And now I would like to go into details of what we should do in practice in these patients to implement our evaluation until the multidisciplinary one. Okay, first of all, I think it's essential to define type 2 inflammation. As you have already said, it's very important that type 2 inflammation should be very likely to be in these patients. Sometimes it's difficult to define type 2 inflammation in these patients, but we can look at blood eosinophilia, at local eosinophilia, at serum IgE that can help us to define type 2 inflammation based on the cutoff values suggested by the EPOS and Euphoria group. Also in the last publication in April 2023. And it's also important to look at previous histological findings and the coexistence of other type 2 comorbidity, such as asthma, atopic dermatitis, esophagitis. And after that, it's very important to confirm the bilateral diffuse disease. And for that, we can perform an endoscopy, and we can undergo a CT scan. Better if we can do together both. And after that, we have to define the severity of the disease. In Italy, we have to define the severity for prescribing biologic. We have to define the nasal polyp score that should be greater than 5, and the SNOT-22 score that should be greater than 50. And there is a little discussion about this cutoff, because for someone is 40, for someone is 50, but in Italy, from a governmental point of view, we have to respect the cutoff of SNOT-22 greater than 50. And that is not enough, because we have also demonstrated that the disease is uncontrolled. And in Italy, we defined uncontrolled disease when cases have seen significant symptoms despite continuous use of intranasal corticosteroids, and if there is a failure after a previous surgery and or previous use of systemic steroids.
So, Eugenio, could you share with us some tips or how you structured this complex approach in your clinic?
Okay, Marco, obviously you are right, because until that moment, we didn't speak about how we manage our multidisciplinary approach. So when we started several years ago with our experience with biologics, we realized that the multidisciplinary approach was very important in order to define as precise as possible all the comorbidities in the same patients. For that reason, we created a special group that we named the type 2 inflammatory group, and we involved in this group allergologists, immunologists, rheumatologists, and dermatologists and pulmonologists. So every one can share their patients in the groups, and we tried to do our best to make the evaluation very fast. And in that way, we try to make that the patient journey as briefly as possible. So, and at the end of the evaluations, we used to met together in a board in presence and discuss the patient all together. And we try to focus on the drivers of severity, that sometimes the driver of severity is chronic rhinosinusitis with nasal polyps. In other patients, the driver of severity is asthma. And this is very important to underline. And after that, we try to discuss together which could be the best treatments for the patient, so the best biologic to choose for a specific patient. And only after that discussion, we start with the treatment. But before the treatment, we try to plan as precisely as possible the roadmap of the first year of treatment. So right at the beginning, we understand that the first two evaluations were very important. At the baseline, we have to inform very well the patient about the treatment, because the patient should be ready for the first year of the treatment. And it's important to train the patient on the self-injection. And we used to do the first one and the second injection after 15 days in the hospital, because this make more confident the patient, and we feel more sure about potential adverse event when we start with a new treatment. But after that, we check the patients every 2 months, and every check we try to look for safety and effectiveness and evaluation of all function, and we try to understand if comorbidities are going better. But after this first approach, we're changing our roadmap on the first year of treatment, because we realized that the first evaluations should be more closed, but lately we can postpone the evaluation every 3 months. So actually we check, currently we check the patients at baseline, after 15 days and after 1 month, and lately at 3 months, 6 months, sometimes 9 months, and finally at 12 months. And I want to underline that the 6-month evaluation and the 12 months evaluation are very important from a regulatory point of view, because we have to check for efficacy, because this is needed to prolong the treatment over the months. And a special mention should be made for a patient with comorbidity, about comorbid patients with nasal polyps and asthma. They are special one because the burden of the disease on the quality of life in these patients is higher. And in this publication, we summarized potentially scenarios that we can face with these patients and the possible interaction between different specialists. And I would like to start with the first scenario, that is a patient with severe uncontrolled chronic rhinosinusitis with nasal polyps that should start with biologics, but he complains about asthma symptoms. So in that situation, I would ask Marco to do a clinical evaluation. And now I would like to ask Marco, what type of evaluation would you do in that patient, in that case?
Yes, thank you for the question. It is very much relevant indeed. Well, first of all, each ENT specialist should always ask to the patient about lower airways symptoms in order to suspect at least the presence of coexisting bronchial asthma. In that case, a proper diagnostic workup should be performed by the allergist or the pneumologist, and it will include both patient-reported outcomes like asthma control test, for instance, or ACQ, but also lung function evaluation through a spirometry or bronchodilator test, methacholine challenge tests, and of course, a wider evaluation on other T2 condition or other coexisting systemic diseases. That is very much important in order to depict a full clinical profile and to define the best option, the best treatment option for that patient. But let's imagine another scenario. So we have a patient with severe asthma who needs to start a biologic therapy because it's difficult to treat bronchial disease. And we have to be aware that his or her nasal comorbidity may have a relevant role or impact on the lower airways disease. So in that case, how should we behave for correctly identifying the major disease drivers for that patient, Eugenio?
So that's very important, because you have to define in these patients which kind of disease is affecting the nose. So it may be an allergy or a non-allergic rhinitis, or more frequently a chronic rhinosinusitis with nasal polyps. So it's crucial to analyze symptoms, to investigate on olfaction and especially on smell impairment, because this is typical of chronic rhinosinusitis patients. And it's also essential to score the symptoms, evaluate the burden of the disease on the quality of life, possibly with the SNO-22. And after that, it's necessary to perform an endoscopy, and if needed, a CT scan, because we realize that it's very important to define as precise as possible which comorbidities is associated to asthma. And you know that if nasal polyps are associated to asthma, the burden the disease is much higher.
Thank you. That's very helpful. Another situation we are quite used to, let's say, face is a patient with an ongoing biologic therapy for severe asthma, still complaining about nasal symptoms. In other words, a patient well controlled in terms of bronchial symptoms, bronchial disease, but with an upper airways involvement out of control. So, which is the best way to manage that kind of situation?
This is a particular situation, and we know that fortunately, biologics are effective both on the upper and lower airways. So, but sometimes the response is not concordant, and you can have a good response on lower airways, but not a good response on upper airways. And in that situation, we have to repeat the additional workup. So we have to try to investigate the reasons why the patient has not a good control of nasal symptoms. So we used to redefine the treatable traits and repeat endoscopy, try to understand if the previous surgery was adequate and complete, or if the patient never underwent surgery in the past. We have to understand if surgery is needed in these patients, because we have to remind that we can repeat surgery during the treatment with biologics for asthma to improve control of nasal symptoms. Another crucial point is to look if the patients are adherent to the local treatment. And sometimes you can see that these patients are not adherent to the use of local intranasal corticosteroids. And if after all this consideration, we cannot improve the control of nasal symptoms in other ways, we can consider finally to change biologics. In that case, it's important discussion with our pulmonologist in order to understand which could be the best biologic to choose for a shift.
Thank you, very, very much helpful. Going to the final remarks of our interesting talk. how is it possible to implement, to start with a multidisciplinary approach in every kind of setting? Well, first of all, the aim is to increase awareness about the condition we are going to treat, um, by organizing hospital meetings or case discussion or journal clubs according to the specific feature of the clinical setting we are working in. And another potential strategy is facilitating an intra-unit referral, meaning identifying one or two colleagues who serve as the reference persons for the patients suffering from nasal polyps. It is very much helpful in order to structure a track fully dedicated for those patients. And then that kind of focused expertise should be shared with all the specialists who can interact or who can detect a patient suffering from NP and who can share with us their specific expertise in terms of coexisting condition or comorbidities. What I'm showing you now is just a very quick overview of about how our center is structured. So we have a general outpatient clinic which collects patients from the GPs, from ER as well. And then we have some dedicated tracks. We have the asthma outpatient clinic with the ENT outpatient clinic, the severe asthma multidisciplinary group, the biologic treatment clinic, and also a group dedicated to dysimmune hypereosinophilic diseases and transitional care clinic run by together with the pediatricians. And different specialists contribute to the good management of all those clinics, from pulmonologists to ENT, pediatricians, us are perfectly aware and somehow sensitized to ask all the patients we visit about their upper airway symptoms. And if it is the case, we address them to the rhinoallergy outpatient clinic, which is run together by an allergist and an ENT specialist, where the patient can be addressed to all the diagnostic tools in order to correctly define their condition or the potential coexisting diseases as well, and where they can find reference doctors with a specific expertise in upper airways condition with potential systemic involvement. So it is something that we schedule both for a diagnostic workup at the beginning of the story, but also for a proper follow-up over time.
So thank you, Marco, and for your talking and for the great discussion of today. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support for this important educational activity. And please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session along with other sessions on demand. So my name is Eugenio De Corso, and thanks again Marco Caminati from Verona. Thank you for joining us today. Bye.
we're going to have Dr. Caminati redo slide 41, and then we'll see if there was any other comments from the team.
All right, we are still recording.
All right, I'm going to shut my camera off. Dr. Caminati, 7, 6, 5, 4.
So what I'm showing you now is the structure of our asthma center and allergy unit. So we have a general outpatient clinic collecting patients from the GPs and from the emergency room as well. And then we have some dedicated tracks. We have the asthma outpatient clinic, the ENT outpatient clinic, or a focus group on severe asthma patient, and a biologic treatment outpatient clinic as well. And another multidisciplinary group dedicated to this immune hypereosinophilic condition. And last but not least, we run a clinic together with pediatricians for the transitional care setting. But all of us are completely aware of the importance of asking to our patient about the upper airways condition. And if it is the case, we address the patient to the renal allergy outpatient clinic, which is run by an allergist and AMT specialist together. And there, the patient can be addressed to all the further or additional diagnostic procedures for a complete and detailed profiling of his or her condition according to a systemic approach, and there we can schedule a proper follow-up in relation to the treatment we prescribe at the beginning, and which needs, of course, to be regularly monitored and retailored according to the patient's response.
So thank you very much, Marco, for this great description of your models in Verona. And thank you very much for the great discussion of today. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session, along with other sessions on demand. So my name is Eugenio De Corso from Rome. I would like to thank again Marco Caminati from Verona, and thank you finally for joining us today. Bye.
Bye.